Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have a very special guest, Dr. Kay Lovig. She's with White Plains Physicians Associates. She's an endocrinologist. Welcome, Dr. Kay.
Thank you. Thanks so much for having me.
How are you today? So,
great.
Tell us about your specialty, endocrinology. Not everyone really knows what an endocrinologist is and what you focus on in your practice.
Sure. Yeah, it's basically a big long word that I basically focus on all of the endocrine organs, which are hormone producing organs. So thyroid, diabetes. Additionally, it focuses on metabolism. So one of my interests in particular is weight management and just dealing with the obesity epidemic that has happened in our country.
You mentioned the thyroid gland. It's a small little gland right up in the neck, and not everyone knows what it does in the body. Just describe the gland and how important it is to our metabolism.
Yeah, so actually January is thyroid month, so we're currently in thyroid month, so that's good. So it's a gland that sits in the bottom of your neck. It actually looks kind of like a butterfly, and interestingly enough, it really helps regulate. I mean, people I think who are a little bit familiar with it think of it primarily as regulating our metabolism, which it does, and that is true. However, it actually affects almost every organ on our body. So most organs have thyroid receptors on them, and it helps, our heartbeat, it helps our temperature regulation, our metabolism, our mentation, our mood. So
it's an important gland, obviously, and there's a lot of different types of disorders that can occur with the thyroid gland, hypothyroidism, hyperthyroidism, Graves' disease, various things. People can have nodules or even thyroid cancers of some kind. Hypothyroidism, I think a lot of women in particular and some men, it's a pretty common situation, syndrome, disorder, whatever you want to call it. Why do you think it's such a prevalent problem in our society?
That's a good question. I don't know that there's one exact answer to it. In general, the most common disorder that occurs in thyroids is having an underactive thyroid or hypothyroidism, and of which the most common cause of it is an autoimmune condition called Hashimoto's disease. And it is one of the more common thyroid dysfunctions that we see, and about 10% of the population have an underactive thyroid. Now, worldwide, the leading cause, like in third world countries, is due to iodine deficiency, but obviously we don't have that so much in Northern America. So why it's as prevalent as it is, I don't think is well understood, but it kind of falls in the same category as all other autoimmune diseases like type 1 diabetes, rheumatoid arthritis, and so on, but it's one of the more common ones.
Now, the typical diagnosis would be through a blood test for a thyroid condition?
Yeah, so the first step in diagnosing if you have some thyroid dysfunction is blood tests. It can get a little bit more complicated depending on what the problem is, particularly if you have an overactive thyroid. So sometimes we need to do imaging of the thyroid to kind of see what part of it isn't functioning correctly.
And autoimmune, sometimes we don't know what causes these things, and it's idiopathic sometimes, right? So is there any prevalence for environmental causes, whether it's cell phone or electromagnetic radiation or other types of environmental in foods where maybe that could be some underlying cause? Because you've heard of subclinical hypothyroidism, and people have slightly underactive thyroids versus like their TSH is way up, and it's a kind of an easy diagnosis, and then there's other people that are just a little sluggish, slightly depressed, maybe a little weight gain, but nothing else is wrong with them. So I know there's no direct correlation, but
it's a really good question. I think in everything in medicine, we don't know everything. We're always learning new things all the time. Certainly the most prevalent cause is the autoimmune condition, and there's not, other than having a genetic predisposition, which we know puts you at risk for having it, we don't have a clear understanding as to why does your own body kind of start to attack your thyroid. And I think, it would be wonderful if we could determine that, because I think it would help treat a lot of autoimmune conditions. In terms of other environmental things, we do know that radiation exposure to the neck puts you at risk for having an underactive thyroid or thyroid cancer. Thankfully, I have patients who are 80 years old. They, said that when they were 20, they were getting radiation to their face for acne treatment. We know better now, and we don't do that. But certainly people who have had, chemotherapy and radiation for something else, they're at increased risk. And then, like I said, there's a clear link with iodine deficiency, but that's just not something that we see that often
And
here.
treatment protocols for, hypothyroidism. Well, let's talk about symptoms for a second, because
Sure.
sometimes people, they may not know what's going on in their body, and they can't figure out, why am I gaining weight? Why, am I tired? Why am I, having hair loss, and brittle nails and all these other issues, or dry skin? Are those are some of the symptoms that people should be aware of? That'd be one reason to get their thyroid checked.
Absolutely. Yeah. So one of the tricky parts of it is kind of what you're alluding to. There's a lot of vague symptoms that, who isn't tired most of the time, especially if you're, what I told my parents, we're all tired, but still, I mean, if you have significant new fatigue, or like you said, I mean, change in bowel habits, change feeling your heart beating differently, change in temperature sensation, mood, irritability, depression, those could all be a sign that your thyroid is not working properly. So it's tricky, it can present in so many different ways that can be tricky, but thankfully the test to see if it's working correctly is fairly simple.
Pretty straightforward.
Yeah.
And the opposite of hypo would be hyper, and that comes along with its own set of symptoms that might be almost opposite in some cases, right?
Exactly, yeah. What I tell my patients who have hyperthyroidism is that it's almost like your body is on a marathon 24/7 without you realizing it. So you might have trouble sleeping, you get fatigued easily with exercise, your heart is racing all the time, you feel hot and sweaty, you have weight loss. So, I mean, sometimes a lot of people are happy with the weight loss, and then as it progresses, they think, okay, well, something else is going on. So.
Now, treatment protocols for, hypo, let's just say, typically some kind of replacement, thyroid replacement, or what are the other options?
Yeah, so unfortunately, if you are someone who has an underactive thyroid, most cases it's not, especially once it gets to a certain point, the function doesn't just return back to normal. I get a lot of questions from patients about, I think especially in this area, people are very educated, they take much better care of themselves than a lot of areas where I've trained, and people want to know if there's something they can do to improve their thyroid function, what did they do wrong, and the happy answer that I can give them is that there's nothing they did wrong and there's nothing that they can do differently, unfortunately, which can also be frustrating, understandably.
Yeah, it's one of those things, you just have to get it regulated to some degree and get them feeling better, and then take the next steps and see what's going on.
Yeah, exactly. And another reason I really love my field is that, unlike a lot of, doctors, I think, get a rep for wanting to put patients on just lots of medications all the time. And, I myself am not someone, I just don't like to throw medications at people unless the benefit really outweighs the risk. But thankfully, in my job, a lot of the medication that I'm giving people is just an identical hormone to what their body is deficient in. So I don't even have to go over what the side effects are. With for example, thyroid disorder, people typically take levothyroxine or Synthroid. It's just a bioidentical version of what your body should be making.
All right. Now, there's synthetics, I guess, what they consider synthetics or man-made, replacements. And there are some doctors out there, maybe more integrative alternative, that will treat more with glandulars, like Armour thyroid, things of that nature. What's your thought process on those?
Yeah, so I think that thyroid hormone replacement has changed a lot in the last, 30 or 40 years, so what's available to us. I think the first and foremost therapy that people should try is the more synthetic types like Synthroid or levothyroxine. And the reason for that is just that so what those are they're bioidentical to something called T4, which is the primary hormone your thyroid makes. And it's a hormone that lasts for a long time. So what I tell patients is if I was to take out my thyroid today and not have any thyroid, my thyroid hormone levels would stay stable for about 7 days, and then it would slowly start to decrease. So those synthetic brands are that long-acting, and again, it's mimicking primarily what our own thyroid makes, so people don't bounce all over the place in terms of how they feel.
More easy to regulate the levels.
And get their levels more normal and feeling, consistently at a certain level all the time. With that said, I'm not opposed to trying other therapies if people don't feel like they feel well on it, as long as, first and foremost, do no harm, as long as their levels are in a safe range. I think it's certainly appropriate if someone is, their numbers are great on the more traditional replacement, but they say, I just don't feel well. I don't know if it's my thyroid or if it's something else. There have actually been some interesting studies that show that there are a small percentage of people that when they went on both a combination of T4 and T3 replacement, so that being Cytomel or in some cases, Armour Thyroid, they just say that they feel better. They didn't tend to have changes in weight more so, but they just had better energy and felt improved.
So in some cases you replace both the T4 and the T3 levels, depending on,
Definitely.
and will you test for free T4 separately or?
Yeah, so free T4 is a better test than T3 in general, just because there's such a small amount of T3 that is typically in our body, and the assay for it is not great. So when someone's on T4 and T3, I'm more looking at, this is more like doctor talk, sorry.
Yeah, that's okay.
Their TSH to see kind of how their numbers are. The problem with T3, which is, for those who are familiar, is also called Cytomel, is that it's a medication or a hormone that acts very quickly and it stops working very quickly. So it lasts about 4 hours. So in order to kind of not feel horrible all the time, you should appropriately at least be taking it twice a day, which
and I think what you said before is important. You're treating the patient and not the blood test, and
Absolutely.
You're treating how they feel, what their symptoms are, do they feel better with this level of medication?
Right.
As long as there's some good correlation with your lab tests, ultimately it's do no harm, is the patient doing the best that they can do.
Yeah, I think as long as their levels are not in a dangerous, we know that there's risks associated with having too much and too little. As long as they're not in that place, if they feel better on one replacement than another, that's great. That's the point.
Now, hyperthyroidism, being the opposite to some degree, is a little bit different because you have to control the thyroid. In some cases, you actually have to either remove or kill off part of the thyroid.
Right.
And then you end up kind of reversing back to hypothyroidism.
Exactly.
So, are there any alternatives for hyperthyroidism that doesn't necessarily not destroy the gland, but reduce the ability for the gland to work on its own?
Yeah, that's actually a great question. So there's different causes of an overactive thyroid being hyperthyroidism. The ones where your gland is making too much hormone, there are medications that you can go on that slow down the amount of thyroid hormone that they're making. The issue with them is that, as I was kind of saying before, I completely understand not wanting to be on a medication lifelong if you don't need to. And so the medications that you're giving people for an overactive thyroid have side effects and adverse things that can happen if you're on it for a long time, as opposed to levothyroxine or Synthroid, again, just being the hormone that doesn't have dangerous side effects associated with it. So commonly, if I have a patient that can, I'll put patients on medications that slow their thyroid down. And if their thyroid if they remain unable to come off of those medications after a year or 18 months, I start talking about, wanting to consider other treatment options. Obviously, it's up to the patient, but, not wanting to subject them to the long-term risk of those medications.
Now, if someone has nodules or hot nodules, or if you do certain types of uptake tests, those types of patients, there's a small percentage that do have cancer of the thyroid. It's not a high percentage, thankfully, but it does occur on occasion.
Right.
And those you'll coordinate care with those specialists for that type of.
Yeah. Actually, interesting. It's kind of a common misconception that endocrinologists are actually the primary physicians that take care of thyroid cancer in conjunction with a surgeon. Obviously, it's not so much an oncologist. It's the only cancer that's actually typically not taken care of by oncology.
Oh, okay. So you would actually handle that with the patient in a surgical manner as well? Or?
I mean, they don't want me doing surgery.
They don't do it. Okay, all right.
We have an excellent surgeon at White Plains. I'm very, very fortunate. So typically they have surgery first, and then there's management and following that needs to occur kind of afterwards, lifelong, typically.
Right. Now, in your practice, I assume hormone replacement therapy is probably a big, thing that you discuss with your patients.
Yes.
A lot of different schools of thought on that topic in terms of, synthetics versus, naturals versus creams versus pills. There's a lot of stuff out there.
Yes.
Some, that probably bear some warning signs, and some that, are a little bit more, mainstream or at least down the road. What is your, how do you work with your populations that are looking for hormone replacement?
Yeah.
Who would be a candidate for those types of treatments? And
like talking about specifically kind of like estrogen, or testosterone replacement.
Yeah.
So those, both in men and women, are very hot topics, and as you kind of alluded to, they've been controversial. And I think probably in endocrine, they're especially with testosterone replacement, what we're recommending or what the guidelines are have changed a lot and are continuing to change over the last decade or so. So it's always kind of hard to keep up on it. Like I remember when I was a medical student, they just came out with a Women's Health Initiative, which was a big paper that looked at essentially replacement of estrogen and progesterone in women who were postpartum, typically in their 60s. So like, 10 years postmenopausal, sorry. And found that there was an increased risk of cardiac events and stroke and blood clots. So, kind of, I think as a medical society,
estrogen replacement in particular.
Yeah, went from overly replacing people, thinking that it was actually going to protect women from a cardiovascular standpoint, to being very afraid to give it to women. The guidelines, actually, they came out with new guidelines just within the last 6 or 12 months, I would say, that now say that it's safe to give women hormone replacement therapy if they're having severe symptoms of menopause, particularly hot flashes, but it's felt to be safe or safer during the period of the menopause period. So they don't recommend initiating therapy once someone's past 10 years being postmenopausal, and it's not recommended to keep someone on it indefinitely.
Right.
So the tricky part with that is that the symptoms that you get from menopause are due to the change in having hormone to not having hormone. So by giving someone hormone replacement therapy, which in some people it definitely helps, you're kind of just, you kind of have to wean them off of it so that you're just trying to decrease the magnitude of their symptoms.
Right.
Now, in the last, I would say probably 2 years or so, the issue of testosterone replacement has been extremely controversial. I mean, I think probably if you're home during the day, you can see a lot of malpractice, commercials for it, which is always a good sign that it's a controversial issue. But I think, probably 5-10 years ago, there were,
see a lot of marketing for low T.
A lot of marketing and a lot of people thinking it's like the be-all and cure-all to all of their symptoms. Fatigue, decreased exercise capacity, decreased libido. And actually, interestingly, decreased libido is the one that's most linked to having low testosterone, not so much energy or change in muscle mass. But with that said, similarly, I think physicians were administering it or prescribing it maybe too often, and in their defense, there were no good guidelines as to what is too low of a level, what is too high of a level, and unfortunately, we're now seeing that there's risks associated with it: blood clots, heart attacks,
cancer to some
prostate
degree.
Cancer, particularly in young patients. I mean, in my training, I saw a number of young men who were like getting it on the black market, and it causes infertility that you can't really reverse.
Yeah, we should let our audience know that's not really recommended.
Definitely not.
That's not a good idea because I think people with the marketing and with the buzz, I think people are trying to see what's out there, and there's marketing that there's natural testosterone and natural estrogen or progesterone and all these other things, and I think people have to just pause and do the proper due diligence. Speak to proper healthcare professionals. Even if they do want to go a more natural route and they want to try things a little bit more, maybe natural compounded progesterone or estrogen or whatever options are out there for them. At least work with a professional, I think.
Yeah, I mean, because even the natural hormone replacements, they still have the same effects. It's not like, they're any safer from that regard. And in some people, it's absolutely appropriate and should 100% be considered. You talk about the risks and benefits, but it's not something that people should just think is safe and, why isn't everybody on it? And it's the,
And you would do blood tests for these types of things as well?
Yeah, well, for men, yes. For women, less so. So typically we just look kind of at what, if they're, again, the indications to treat, or if they're perimenopausal or within 10 years of going through menopause and having severe symptoms, particularly hot flashes, which is only the only symptom that tended to improve consistently with hormone replacement therapy. Whereas with men, the blood assays are much better now and you know, can give you a good assessment of how much active testosterone they have.
Okay. In terms of diabetes, I'm sure as an endocrinologist, that's maybe some part of your practice, a big part of your practice. You know, there's different types of diabetes, type 1, type 2, juvenile, you know, et cetera. It seems like that's a pretty big problem in our country. And you know, I as a healthcare professional, you know, I know a lot of it's preventable, but you know, how do we get that message out to the public, and what do you know see in your practice in terms of like education and you know and just even reversing? I'm a big believer you could take a type 2 diabetic, and if they do the right things, they could really get rid of it, but they have to you know be diligent in what they do, and depending on what stages they are. But
yeah, no, it's a really good question. It's a huge problem in our country. At the American Diabetes Association last year, I think they mentioned that 1 in every 5 healthcare dollars are spent on diabetes.
Yeah, which and is billions and billions of dollars.
I mean, it's through the roof.
And all the side effects of it, you know, because you know there's so many other things that happen with diabetes.
Blindness, renal, kidney failure,
ulcerations, and you know,
exactly.
heart disease.
So it's just it's a tough disease, and you're very right in the sense that with type 2 diabetes, the one that typically occurs in adults, interestingly enough, it is actually more hereditary than type 1, which I never actually realized until I went through my training. But with that said, there's a huge environmental factor, and if early on in the disease, by monitoring and changing your diet, particularly you know decreasing not just sugar but simple carb intake, and having mild to moderate weight loss, because the more you know excess weight we have, the less sensitive our body is to insulin. So that's one of the biggest issues with type 2 diabetes, that people can really reverse it, or at least you know delay needing to actually be on therapy for it or medications.
Will you treat them, you know, with medication to start to control those sugar levels, and then see if you can implement some lifestyle changes along the way?
Yeah.
Just so you kind of have a balance there.
It totally depends on how severe their disease is. So 100% all of my patients, there's a huge component of it that is lifestyle, dietary, because whether you're a newly diabetic, a severe diabetic, or anything in the middle, that is always going to be a huge part of how you monitor it and regulate it and controlling it. But how, you know, if it's someone that's presenting early on in the disease, I will definitely give them a trial if they seem motivated enough to really work on changing their diet, exercising more, having a little bit of weight loss, and it's amazing the results that you can see. People that are
reverse the whole disease process.
Yeah,
really.
Exactly. People that present, you know, maybe they weren't seeing a doctor regularly, and by the time they come to me, they have fairly significantly high, you know, levels in their blood sugars. I'm more cautious to just let them go on a trial with no medication, just because of the risk of having such high blood sugars. I mean, it's dangerous for your
now,
all of your
are there
blood
tests
vessels.
that are good markers to see if you're prone to being a diabetic, with H1AC?
Yeah, hemoglobin A1C is probably the test of choice now, which basically is a blood test that gives you an average blood sugar over the past 3 months. So it's a really good way to get a snapshot of how someone's blood sugars have been over the last 3 months, and you can diagnose someone with having pre-diabetes with that, or having diabetes or advanced diabetes. But in terms of like a genetic test, there's no genetic test that we can use. Yeah.
But that test can be useful if you think someone's borderline, or they're starting to creep up, or if you've been tracking a patient over 6 months or 6 years even, you say, hey, I don't like this trend here. Let's cut out some of the sugars, the alcohols, maybe do some more exercises, and coordinated effort with other healthcare providers, nutritionists, personal trainers, other people that are involved in the health and wellness industry. It can be useful to coordinate care. As a doctor, you're busy running around from room to room, and just really taking the time to track and monitor a patient with other providers can be useful, I would think.
No, definitely with diabetes is a disease that is hugely affected by our environment, what we're putting in our body, what we're doing with our body, and it really takes an entire team to help manage that person and get them healthy.
Yeah.
It's not that, any disease is easy, but it's just not as easy as a fix as a lot of other conditions that we treat.
And you mentioned diet. I think everything we've spoken about tonight, there may be some dietary triggers to a lot of these things. I believe, personally, that certain autoimmune issues are triggered by sensitivities and allergens and things that our bodies don't process. I know there's not a lot of science on this stuff, but I believe there's enough research to show that things that our bodies don't process well creates this autoimmune or defense mechanism, and that inflammation built up in the body, whether it's someone being allergic to certain foods or certain dairy or other things, or it's not even just the dairy and the foods and their purity, it's the dairy and the foods that we're eating in today's environment, which aren't the foods that our families ate, generations and generations ago, where there's a lot of additives, a lot of preservatives, a lot of chemicals. It's not the same, and I think personally that there's a correlation with that and our effects on our body. So.
Yeah, I mean, it's hard, obviously, to say definitively, and kind of like you said, there's no, I believe there's a lot that we don't know in medicine. Obviously, we're learning new things all the time. I actually had a patient asking me about this today, and whether or not there's truth in that, I certainly don't know, because there's no studies that ever looked at it, and it would be a very hard, everything in Western medicine, we're always looking at what's the evidence. We focus on evidence-based medicine and having good studies that were done to help us compare, like, what is better, what is the true cause. And in something like that, I think it's, maybe someone could get a grant for it down the line and look at it.
There's a lot of things
it would certainly be interesting to know. Whether
food choices in general, just we can surely say, that's a good food choice, that's a bad food choice, and then too many bad food choices over time, can lead to disease. I think they did that silly McDonald's thing, but
in particular, in obesity,
that is evidence-based. You eat McDonald's for 30 days, you will be sick.
That's very true. Yeah, no, I mean, certainly with with weight issues and insulin resistance and obesity. What I tell patients is, we were meant to be living on fruits and berries and, killing our prey and running around and not knowing when our next meal would be, not sitting at a desk job, having minimal activity, driving from place to place and having food that's plentiful and never having a loss of meal with lots of, additives in it. So it's tough. We live in an environment that we were not, meant to be.
So for your profession in particular, it's tricky because you see the end result, you're not sure of the cause, but and you have to treat the patient. So it's frustrating for the patient sometimes, frustrating for the doctor sometimes, but at the end of the day, you're trying to balance all that and just maybe trying certain things that are maybe a little bit off the beaten path, elimination diets, remove certain things from the diet, see if it does have a negative or positive effect from that person's health, and see if there's triggers. I mean, thankfully there are certain IgG, IgE tests that can be done for even like rheumatoid arthritis, other immune problems, to see if are there triggers, what's really causing these problems.
Right. So. I mean, like you said, we don't know. So it could, like we were saying earlier, we don't know the exact cause. So it's very plausible that any of those are true. I mean, I had a woman that I saw today who has autoimmune thyroid disease and was wondering if there was anything she did in her diet, or if she eliminated something, would it make it better? And what I tell patients is I have no studies in front of me to tell me that certainly it would make a difference. But if you want to try and eliminate it and see if you can make a difference, if that does make a difference, I have no problem, as long as we're following you closely and you're not getting into dangerous levels, at which point I would say, okay, we need to do something.
Now, diabetes obviously increased weight. Now, just because people have weight issues doesn't mean they have diabetes, and obesity leads to other problems, cardiovascular disease, vascular disease, whatever, just low energy, low self-esteem, depression. There's a lot of things that go along with that.
Many comorbidities.
So for someone that's not in a disease state yet, but they maybe, do have some weight issues or weight management is a problem for them, working with those patients, you test everything, thyroid's good, everything looks good, you're like, but person's, how do you manage just that type of patient?
That's a really good question, and it really depends on the patient. So first and foremost, I do a lot of
because there's no diagnosis
counseling.
except for the weight.
Yeah, I mean, so again, even if people tell me, I'm not eating that much, or I don't know what's happening. Number one, our metabolism slows as we get older. A lot of the foods that we eat, we just weren't meant to be eating. We live in an environment we weren't meant to. And I counsel people to keep food diaries for me so that I can kind of help and guide them. I give them some good instructions on, what they should be doing. And then there's all sorts of more intense things that people can do. So if somebody is interested in doing a full meal replacement diet, I'm happy to do that with them. If they're interested in, certain people qualify for medical therapy to help them lose weight. If they qualify and have no contraindications, that's something I'll do. And then obviously if people are interested in surgery, I don't do the surgery, but I can refer them.
But hopefully, as a last resort, if that's the only
so
thing
usually that's kind of how the stepwise,
like
I would never tell someone to just go and get surgery. First and foremost is always trying to work on diet, trying to work on exercise, elimination diets.
Some of these crash diets, you have to be careful. People try and do too much too quickly, and they just don't manage it well, and they either get sicker or their blood sugars drop too low, or they have other problems because they're trying to eat too little. And sometimes there's a balance of having enough calories to get you through your basic physiological needs, and then moving forward from there. So it's kind of another balancing act in working with nutritionists.
Yeah. Absolutely.
Now, do you work with osteoporosis patients?
I do. Yeah. So that's another.
So that's a nice little topic. Something with women, and it kind of probably works with the HRT a little bit. Sometimes they don't know if, estrogen, if that's the appropriate treatment, or what other types of medications. Some of them, do you feel osteoporosis can be worked just diet and exercise, or do you feel like people need Fosamax or other types of medications that are out there now?
It depends on, again, how severe it is. So, if they're kind of borderline and they want to give it a trial, we know that, I would say first and foremost in terms of, a nutritional aspect is vitamin D deficiency. I would say about 90% of patients I see are vitamin D deficient because we put sunblock on so we don't get sun cancer, and we're inside most of the day.
And that's with or without osteoporosis, just vitamin D deficiency.
Is a problem, but certainly if you have osteoporosis, it's a big problem because it puts extra strain on your bones to get a source of calcium, because you need vitamin D to help absorb calcium from your gut. So that's an issue, making sure that they're getting enough calcium in their diet, whether it's dairy or soy products or green leafy vegetables, and then weight-bearing exercise, which is actually a common misconception. People think they need to be going and lifting weights, but it's actually just doing something that has an impact with your body, like walking or jogging, a few times a week are the mainstay of therapy to start with.
Do you do bone density testing in your new office there?
Yeah, we do. Yeah.
And you'll do, is it a full body scan, like the spine and the hip and the wrist?
Yep, it is, but it's minimally invasive. It's almost more like it's low radiation, less than an ultrasound. It's
It's actually very cool machines. We used to do them in my old office. So,
oh, really?
Yeah. So now, any other particular conditions that interest you, or are things that you see in your office, or?
Things that I see in my office, I also see a lot of polycystic ovarian syndrome. So that's a condition or a syndrome that affects a lot of young women. Typically manifests as having irregular periods and having kind of an imbalance with how much testosterone they have in their body, and is also linked to having insulin resistance, like a precursor for diabetes.
Is that genetic based, or not necessarily?
There's no genes that have been found to be linked with it, but it's certainly very plausible.
Right.
It's
is
not
it
something.
A strong family history, not necessarily.
You can have a family history, but it's not like there's a gene that we know of, right? But it's also not that there's, again, something in that condition that people are doing wrong. It is, however, interestingly enough, as I was saying, part of the pathology that happens with it is believed to be that there's a drive for insulin resistance, making people's insulin levels high, which is the drive to make you make testosterone inappropriately, which is kind of crazy. So that is actually another condition where in about 30% of people, if they had modest weight loss, that in and of itself could correct the problem. So making their periods regular, having less manifestations of high testosterone
And what
levels.
would a treatment protocol for PCOS be?
So again, depends on the patient. Certainly doing a trial of, not all patients with PCOS are overweight, but in cases where people are overweight, it's, again, any excess fat tissue we have just makes us further more insulin resistant. So it depends on the primary symptom that they're coming with that's bothering them, if it's versus infertility or having bad acne or facial hair growth or irregular periods. But so I would say second to diet, the next
the hormones are
step would be
definitely,
like birth control pills, something
Okay,
to
to
kind
regulate.
of overdrive their own inappropriate hormone production to kind of take over. And then interestingly enough, actually, there's a medication that we use for diabetes called metformin that you can use to help regulate people's periods. It basically lowers your insulin levels, makes you more sensitive to insulin. It's also been linked to improving chances of fertility in people with PCOS.
Now, a lot of the things we spoke about today, are hormone related, thyroid and diabetes and just different syndromes. I'm going to throw out something, not controversial, but soy. Soy is like one of those things people freak out about. Too much soy is no good. Not enough soy is no good. What type of soy do I eat? What type of soy do I not eat?
Right.
GMO soy. People get freaked out when they hear soy. Is there a link to soy and estrogen problems, soy and cancer? Certain types of soy are no good,
That's a really, really excellent question. So it is kind of somewhat controversial. I mean, I do, but it is in the sense that there are what we call phytoestrogens in soy. So that's like a plant almost based estrogen. So for example, if somebody had a history of breast cancer that was hormone positive, like responsive to estrogen, I would encourage them to not take in a ton of soy or try to eliminate it as much as possible if they didn't need it. But whether or not it's the root cause of some cancers, I don't know. There's no evidence to say that it is, but I'm sure obviously it doesn't help things in the event of having something like a breast cancer that's in part caused by excessive estrogen or receptive to estrogen.
Right, so basically, excessive anything may not be good for your body.
Anything in excess is not.
So just regulation, moderation,
Right.
and then, but you'll look at people's diet to make sure they're not having too much of a particular type of food. 'Cause sometimes,
Definitely.
like even sushi, mercury poisoning, people sometimes do a little bit too much. They don't even realize that they're doing it,
Right.
and they can put themselves at risk and harm. And the body hormonally can be affected just the same way by certain foods,
Exactly.
potentially.
Yeah.
So that's very interesting.
Yeah.
Well, Dr. K, it was a pleasure having you
Thanks.
on the show here. I think it was educational. People learned a lot, and they can find you at White Plains Associates over in Armonk at your new
Yes.
facility.
Yep.
Wonderful, beautiful facility, and I wish you best of luck there.
Thank you.
All right, so
Thanks for having
coming.
me.
All right.
Thanks.
Thank you for watching Health IQ. I'm Dr. Alan Siegel. We'll see you on the next show. Bye-bye.